Dick?
It's Jonathan on Nosandra's account, but yes.
Hi, Jonathan. Nosandra.
Hi. Yes,
I'm here too.
we're trying all ways to get in touch with him.
He's covering our day hospital, so I wonder if we should just probably start. And Marcel, are you able to introduce Rada maybe?
Yeah, I'm trying to Google your biography.
Oh, it's okay. I can introduce myself. I know.
Why don't you introduce yourself, and then we'll make a more formal one at the end.
Yeah, we're sorry, Rada. I just Dick is on call, and it's possible that he's tied up, and it's not fair to keep you hanging. And we're excited to hear what you have to say.
No,
Exactly.
that's totally fine. I'm just gonna try to share my slides and make sure everyone see them first. Do I have the right screen, or I need to swap?
It's perfect.
Okay, wonderful. Well, thank you so much, everyone, for being here today and for inviting me to give this seminar. So I'm calling today from San Francisco, University of California, San Francisco, which is my institution. I've been here for 11 years. I am professor of bioengineering and medicine with the appointment both to School of Pharmacy, School of Medicine, and also associate director of our TB center here at UCSF. My training is in pharmacology and biostatistics, and I've been working over the last 10 years with data integration and computational projects across many different, not only clinical trials in TB, but also translational projects of bringing novel medicines to patients faster. So that's a brief introduction of myself. And oh, there's Dick. Hi, Dick. I just introduced myself so we can get going. Okay. And today I just wanted to give a little bit our journey about thinking how we can maybe come to a place in TB where we are able to choose the right treatment for the right patient. And all our basically activities over last 10 years in that specific area. So, but before I start, I think, just sort of to remind everyone, and I think everyone on this call knows that our big, like a worldwide NTB strategy defines a very clear milestones and targets what we need to do in order to reduce TB cases and deaths. And clearly, one of the most effective strategies is that we, or no strategies, an effective thing that one can do is improve treatment success, which hopefully will also lead to decreased mortality and less transmission. And not only that is defined in the NTB strategy, I think there's also been a modeling study which was commissioned by WHO to understand if we're looking forward, if we're wanting to develop new regimens and new treatments, what sort of, or clearly once you develop a new regimen, there are many different characteristics that one can optimize. One can optimize efficacy, one can optimize barriers to resistance, one can sort of try to shorten treatment duration, which we are doing as a community intensively. And this modeling exercise showed that if there is one treatment characteristics that's going to make the most difference on the TB epidemic, that is actually optimization of the efficacy. So if we are able with new regimens to improve cure rates and have better outcomes compared to what we have right now with our standard regimens, and this is irrespective of duration, that is something that will truly bend the curve down the line. So just optimizing duration on its own and shortening duration, clearly it helps programs in implementation, but it doesn't really help as much as we're thinking about bending the curve and improving overall goals. So I really like, have this talk with the mind that one simple intervention that we can do as a field is improve cure rates and how basically we can do that. And really the vision that we've been building here at least in my institution and is really ingrained in this understanding that tuberculosis as it is, it's not a uniform clinical entity. Clearly we start with diagnosis, and we want to understand a lot of details about bacteria and the properties of bacteria. And clearly the most common is understanding the resistance profile of the bacteria. But at the diagnosis, we confirm tuberculosis, and we start to try to get more knowledge about variability or variation of bacteria that we're trying to kill. At the same time, when it comes to a patient, the way we differentiate between patients is by the fact what bacteria they're affected with. So we sort of classify patients and drug sensitive patients, or MDR patients, or HDR patients, but never along the way we really take into consideration characteristics of the patient itself. And once the patient presents themselves with a disease, basically what sort of severity of the disease that they're coming with. And that's really the focus of part that we are trying to innovate. And clearly for the various patients with various disease severity, which are infected with various bacteria, we can make a choice of the right treatment and the right approach to cure these patients. And by the right treatment, we don't think only about the choice of the right medicines, but also within the choice of the right drugs, one can think about choice of right duration or optimal duration for each patient, choice of the optimal dose for each patient, and this includes children and special populations, and so on. So there's a much more complexity that we can or details, necessary details that we need to introduce if we want to sort of try to do better than what we're doing right now. And just sort of going back, I think we sort of all know that we do have various treatments for different type of resistance profiles. It is drug sensitive or drug resistant. But however, within the diagnosis of drug sensitive or drug resistant TB, most of the time we are using the same duration and same approach to treatment. And this sort of approach really brings different success rates, around 82% for drug sensitive TB, and clearly going down for different forms of TB. And this is not sufficient and not acceptable. Finally, here I'm showing chest X-rays from 3 different patients here at San Francisco General, where they presented themselves with newly diagnosed smear positive, culture confirmed, rifampin susceptible TB. I'm not a clinician myself. I'm PharmD PhD, but I've looked enough chest X-rays to clearly be able to see that there are 3 different representation of the disease in these images. Unfortunately, the treatment plan for these patients is all the same. They will all get exactly the same treatment: 2 months of HRZE and 4 months of HR. Often we also think about HRZE or our standard of care. I think it is considered as a very good regimen that does result with high cure rates, and it's really very hard to sort of beat that regimen in clinical trials. As we've seen, there's only 1 trial that managed to do that. However, if we look at the rate of treatment success of HRZE across different years and across different trials, we can definitely see that range of treatment success of HRZE is very variable, and it goes down to 82.8%, which was observed in the Offlotab phase 3 trial, which really tells us that even in the context of well-controlled clinical trial, the success rates of HRZE are not what we believe they are, of like a 95% or 96%. They actually are much lower in the field, and really these numbers are much worse in the field where we are sort of faced with programmatic setting. Having that in context, I think our story really started, at least at UCSF, when we were asked to take another look at these large 3 fluoroquinolone based trials that were hoping to shorten treatment duration, and they didn't. neither Oflotab, no Remox, no Rifaquin. Basically, all of them attempted to replace the drug with fluoroquinolone with hope that we can treat for shorter. And the big, I think everybody knows, the big outcome of those trials was that they were not good enough. However, I think the fact that we wanted to focus on was that, yes, there was 93% treatment success in HRZE arms. However, in 4-month arms, we did not reach those numbers. We did not reach 93%, but nevertheless, 84% of the patients were actually cured. So vast majority of the patient, 84% of the patient were actually really fine with 4-month treatment. Yes, it did not work for everyone, but it did work for almost everyone. And I think that is something which we often did not really pay enough attention to, because clearly, if we could identify those patients and if you could say who, at least majority of these patients, who those are, then we do already have a short treatment for them. We don't need a clinical trial. We don't need to showcase on everyone. So we already have options for many patients that are shorter and safer. And really, I think that body of work was summarized in several publications that came out of our team, which I'm showing here, where we basically describe the whole story. But in short, what we sort of done is combine these very large databases with many regimens and many patients, combine various predictors that are assessed in clinical trials on everyday basis, had a very good set of clinical outcomes and applied appropriate statistics. And basically, the big finding was that the profile of these patients that can receive 4-month treatment, no matter if there fluoroquinolone or not, was very much similar across many different regimens. We sort of call that easy to treat phenotype, or we define that with the different subgroup analysis. And contrary, the other group of patients, which we call hard to treat phenotype. So there's this specific group of patients that did not do well, neither in 4-month treatment nor 6-month treatment. So there's specific phenotype of patients, which I will come in a moment to describe in actual definition of it, is really the one that is not doing well and basically was the basis for all of these trials not being successful. So I think the first finding was, yes, we can treat patients shorter already, and we do have sort of a clear phenotype who those patients are that can be easily selected in the field. And the phenotype that we arrived at, it was not clearly you can have a simple way of stratifying them, as we have done in the first publication, but really when we went and looked into more details how to define this specific phenotype, hard to treat or easy to treat phenotype, it sort of it required a little bit more of statistical analysis and more in-depth modeling. And basically, we arrived in combination of 5 factors, which are listed here on the slides, which are 5 baseline factors, and then clearly there's some other additional factors on treatment that can be helpful. And these 5 factors were really like not big surprises. So clearly patients living with HIV was one of the main ones. Very high baseline burden was the second one, and you can see that the size, effect size, how much actually the baseline hazard was increased based on each of these factors, and these are all multivariate and externally validated analysis. Then we've seen that male sex was being a man was a risk factors, and we can discuss that in more details. Why is that? Presence of cohabitation, again, a very known one, and finally a very low BMI. So really these 5 factors come together are the most powerful in sort of defining accurately the phenotype phenotype of easy to treat or hard to treat patient. And once we sort of came up with this phenotype and risk factors, the other thing, the following thing we could do is really come up with estimation of individual hazard risk score, or sort of for each patient based on these factors, we can sort of estimate initial risk score, which is a very simple thing to do. It's a simple algebraic equation, and then based on this individual hazard risk score, we can sort of invert the question and ask if given your baseline risk, given your baseline factors, what is your optimal treatment duration if we are hoping for you to have target cure rates of 93%, which is sort of accepted across the trial. So that's really the way we can ask the question. And basically what we can arrive with is this estimate of the optimal treatment duration given your baseline characteristics. And this is really the part where we are diverging from one treatment duration for all versus actually being able to estimate what your optimal duration can be as an individual patient who present themselves with your own unique individual characteristics at the beginning of the treatment. So clearly we have a lot of like a quantity of people on the call, and one thing is very clear. So this is the estimate. So this is not observed, but based on a large database, which also was externally validated, we think it has a lot of weight. The one point that I want to sort of bring is a lot of these estimates of treatment duration. You can see here, I'm just trying to get my mouse on the right screen. So you do see what I want to show. But many estimates are extremely short. So basically we do get estimates of like 4 weeks or 8 weeks of treatment duration. And one thing that is clear to understand, this doesn't necessarily mean that we do want to treat patients with 4 weeks or 8 weeks. However, I think what we can comfortably do with these low-risk patients, we can treat them with 4-month treatment duration. So we can, because we did that in clinical trials, we tried treating patients with 4 months, and we have evidence that this specific low-risk phenotype actually did well in clinical trials with 4-month treatment duration, and this is the part where we can sort of argue that they can be doing well with 4 months. More importantly, I think the point is that these easy to treat patients, they will do well no matter if they receive 4 months or 6 months. I think, yes, we can shorten, we can improve their quality of life, they can get off the care much sooner, and this is a very large population of the patients. So yes, we can make an impact in this specific group. But more importantly, I think it is important, we recognize that there's this hard to treat phenotype, which we do know it will not do well with 6 months treatment. And these are the patients that will fail the treatment, they will relapse, they might develop drug resistance, they will spread TB in community. And this is really the target group that actually we need to have better interventions for. And one easy one is clearly extended treatment duration. And hopefully down the line we'll also have better regimens. So let me just show you how these simple phenotypes, basically easy, moderate, and high-risk phenotype, how actually they compare when we go back into the database and look how they do when they receive 4 months versus 6 months treatment. So on the left, this is comparison of low-risk phenotype receiving either 4 month or 6 month, and you can see that both of these lines, Kaplan-Meier, are above that target cure rates of 93%, which is again common across clinical trials. And yes, 6 months is tiny bit better, but both of them are sort of, they have very high probability of having high cure rates in this specific phenotype. And this is all for the treatments that have 10 milligram per kg rifampin based sort of regimen. And you can look to the right, the hard to treat phenotype. Again, we can see that no matter are they treated by 4 months or 6 months, both blue and orange line are below the target cure rates. And this is really the point which I'm trying to make, that neither 4 months nor 6 months is enough for this specific group of patients, and they do require longer treatment duration. So clearly, the vision is that can we take simple baseline markers, something that is readily available, and can we sort of, we believe we can already now, even without a 4-month HPZM regimen, we can use what we have on the shelf and treat patients shorter. And maybe extend durations for the patients that do need longer treatment, and in that way we can sort of optimize cure rates and do better when we treat out them. And clearly, in order to do that, one needs some simple tools to help clinicians or help people on the ground to select optimal duration, and that is something we've been building here at UCSF, and we have a number of these very simple app-based tools, or web-based tools, or even calculators, or even little tables, depending what people want to use. So, and here, this is just one example of such a tool where you're able sort of to select your patient's phenotype and basically select what kind of dosing frequency you're able to give, what kind of regimen you have on the shelf, and characteristics of the patients, and basically what would your acceptable target cure rate be. Here we usually use, again, around 93%. And based on that, you can sort of get this estimate of the treatment duration for your patient, and hopefully use that for either for practice or for design of clinical trials. So, so that is the story for all the regimens, like the ones that did not do well, and we've learned a lot. We've learned a lot, and we start this vision about these different phenotypes, and which was sort of accepted in the field, but we never had like a very strong tools and strong direction of the database how you could do it, and how to integrate all these different risk factors and so on. So clearly now we have a new regimen, and high dose rifampicin based regimen for with moxifloxacin, which was non-inferior for everyone. So it is one size fits all type of regimen, 4-month regimen. And here I'm showing basically the results of all tested regimens out there that tried to shorten treatment duration to 4 months. And the top one are the results from 4-month HPZM regimen. And then the other thing we can see is that second runner, which is not non-inferior, but the second best regimen ever is a high-dose rifampicin regimen without moxifloxacin. So this specific regimen did not meet the bar to be effective for all. However, it was very good regimen compared to other things that we've tested in clinical trial. Is very much ahead of sort of Remox or Oflotab based regimens. So so the question is now basically, you know, how these findings from study 31 and first ever successful 4-month regimen changes this thinking about the phenotypes, because clearly the trial has shown that 4-month might work for all patients. That's what the trial was designed to do. So we've done a very detailed analysis of study 31, 53, 49 beyond what has been published in New England Journal. And one sort of first finding that we've confirmed is that no matter that HPZM was non-inferior for 4-month for everyone, there are still risk factors. And basically in the analysis we have of study 31, we have identified exact same risk factors that we have seen earlier on the database of 4 phase 3 trials, which I just shared. So in TB Reflect, our major risk factor was baseline burden measured by smear grade. That was exactly the same thing in study 31, with the difference that this was a richer database. We had more options that measures baseline load, and it looked like baseline gene H per cycle threshold was the most precise one. The next factor we identified in TB Reflect was presence of cavity, yes, no. In study 31, that was a risk factor, but we went one step further because simply the database was much richer, and we had much more information in readouts from chest X-ray, and that's where we identified extent of lung disease, which is sort of measured by involvement of lungs on the chest X-ray as more than 50% or less than 50%. That was really the one of major risk factors. HIV status was a risk factor both in old trials and in the new trials, with the new finding that the risk of patients living with HIV is not coming from the fact that they have an HIV. It was coming from the fact that basically all HIV patients had much lower rifapentine PK exposure compared to non-HIV patients due to drug-drug interactions with ART, with HIV medicines. So before we didn't have PK data, but now we had PK data, so we could explain why we have a risk factor as why HIV infection is a risk factor. The same was for sex. Before we've seen that men's are the risk factor. We've seen that again in study 31, but again that risk came through PK levels. Basically, I'm showing here again, BMI was important in both analysis, and the study location or where the patients are coming from. That is something that is always present. There's a difference between Asia and Africa, the way which we cannot explain. And finally, some more factors came in study 31 because it was such an amazing and rich database. We've also seen that other comorbidities, is diabetes, is the one of the things that we need to look into. So really the findings are, we've learned a lot from large trials, and we are basically learning the same yet again from the study 31. So how does that basically feed into understanding the treatment response by phenotype in study 31? So here, basically, I'm showing comparison of treatment response from study 31, stratified by phenotype and by regimen. So one thing on the left, again, the phenotype is defined by these factors that I've just sort of described using the algorithm which we've shown you earlier. So you can see that if you look at this easy to treat phenotype, which in study 31, we had around 24% of these patients, they've basically, in this graph, I'm showing the results from the control, which is in black, HRZE, and then blue and orange are 2 interventional arms. And you can see that when it comes to easy to treat phenotype, yet again, they all do well, no matter what they receive. Do they receive 4 months of HPZM? Do they receive 4 months of HPZE or 6 months of HRZE? The response rates are above 90, I think 96% for all of these arms. So there's no really difference whatsoever between 2 interventions when it comes in this specific phenotype. When it comes to the moderate to treat phenotype, where we have around 47% of the patients, and we have sort of, this is the moderate to treat phenotype without comorbidities, so without HIV and without diabetes. So this is majority of our moderate to treat phenotype. And again, you can see that there's not a lot of difference between blue and orange. There's a slight difference, but basically both of these arms, the cure rates are very high no matter if moxifloxacin is present or absent in the regimen. And if we can notice, we are 24% plus 47%. We're almost talking about 71% of the patients in study 31. For 71% of the patients in study 31, there was no difference between two regimens. That they both could receive either moxifloxacin containing or other regimen. And really where difference appeared between two regimens, and this is what really made study 31 successful, was the difference in the small subpopulation of a model to treat phenotype with comorbidities, with diabetes and HIV. And again, since we had PK data, we could see that these patients with HIV and diabetes, there was a very significant drug-drug interaction, and TB medicine or rifampicin was much lower. It was just not enough drug, which hopefully is modifiable factor. Hopefully we can actually address that with better dosing. So that simple group had around 6% of the patient. And finally, hard to treat phenotype is the one with large extent of the disease and large burden. That is where we've seen that moxifloxacin actually made an improvement compared to regimen without moxifloxacin. So the moxifloxacin was really instrumental for improving the cure rates in patients with very low PK and patients with larger extent of the disease as measured by various risk factors. Most important is clearly the chest X-ray. So really the learnings from study 31, even if we do have a very successful regimen, is that the hard to treat phenotype is the one that made a whole difference, and is having stronger regimen and hard to treat phenotype is the one that helped the trial be successful and basically push that boundary down. So the question now is, what is it that Moxi has done in hard to treat phenotype versus non-Moxi regimen versus ethambutol, and we believe it has to do with lesion penetration and ability of the drugs to reach these lesions, and in collaborations with Véronique Dartois and others, we are able to measure lesion penetrations parameters in an animal model. We are able sort of to estimate how much drug is in the lungs, is in cavities during the treatment. And one thing we've learned is that if you look at the low risk group, which doesn't have a lot of involvement in the lungs, basically we call this like a coverage plot. We're able to estimate how much drug is at the site of disease throughout the dosing interval. And here we can see there are 4 drugs. In orange is the ethambutol contained regimen. So you don't need to look exactly, count these sort of squares, but the point is that you can see no matter is it HPZE or HPZM, there's a lot of drug in the lungs throughout the dosing interval. So, so there's a lot of efficacious drug which is covering which is above MIC or different sorts of targets in the lungs in this specific group of patients. But if we try to project what do we have in calcium, in cavitary lesions in the lungs at the type of treatment, we know that drugs like ethambutol, pyrozinamide, isoniazid, they do not penetrate at all inside the lesions. And the really only drug that is getting in there is rifampicin and moxifloxacin. And the major difference in hard to treat phenotype is really that we have 2 active drugs throughout the dosing interval in the cavities, while in the patients that received only high-dose rifampicin regimen, there's only 1 active drug in the cavity. And we believe this is what really makes a difference at the end of the day. Clearly, you cannot help treat bacteria with monotherapy at the site of action. And at minimum, we've estimated that in these hard-to-treat patients, they had 2 active drugs at the site of action. So, So these are really like major findings, which again confirm the hard to treat phenotype and the fact that we need to do better in these patients. So I will just sort of, I wanted to skip through a few things and mentioned. So this was the drug sensitive story. So I think so far we have a database of around more than 7,000 patients from clinical trials, which basically is telling us the same. So, you know, there are different phenotypes. Patients will do well with shorter treatment durations. Some of the patients require longer treatment durations, and we have the tools to start introducing that in a practice. So how about MDR? So this was a really wonderful collaborations we've done with your institution, with Dick, who is, you know, you guys leaders in IPDMAs. But, you know, we said, okay, we wanted to take a look if this would still hold in MDR database, and we've used some of these clearly older IPDMAs with the drugs which are maybe not relevant any longer when it comes to WHO guidelines. But nevertheless, I think the point we wanted to sort of look is this very low success rate of MDR-TB patients, and can we actually identify the phenotype of these patients and sort of make a case for the same story. And there basically the idea is to use this large individual patient data and to try to come up with a phenotype in a similar way, and compare that phenotype that we found in DS for DS-TB, basically does it hold for MDR-TB. And basically the methodology was very similar. There was this database was a little bit of the same size as the one we have for DS-TB, so more than 7,000 patients. Clearly it is a program database. It's not the same as clinical trials, but nevertheless it's a real world database. It is it's sort of it has a different flavor, but nevertheless amazing for learning. One thing that, and again, the approach was the same. Can we think about different ways to using some smart statistical tools to come up with specific risk profile that can help us stratify patients in different phenotypes. One thing that was really striking, I think, in this MDR database is that here we are showing the distribution of treatment duration by patients that have treatment success and patients clearly that who died. It's shifted to the left because they died quite soon, and then the treatment that patient has failed. One striking thing was that various and variable treatment duration or individualized treatment duration is already practiced in the field. So that's not something, so that it's already happening. So I think it is recognized that different patients might need different duration. And for that, so it is not like a fixed 6 month or 4 month as we are sort of doing this DS-TB. So the fact that sort of stratified medicine or stratified approach is already out there and being implemented in the field. And I won't go through sort of every details, but I just wanted to show you basically some summary of these results. And on the left, there is a summary of different risk factors that we've identified in MDR-TB database. And the point is that, you know, largely these are same risk factors: older age, being a man, low BMI, patients living with HIV, extrapulmonary disease, high smear, presence of cavities. So everything is the same. Maybe, like, you know, different databases have different sort of way how they quantify these factors. But the point I want to make is that these factors are consistent, no matter is it drug sensitive, no matter if it's a drug resistant TB. And based on sort of these very basic baseline risk factors, if we stratify the outcomes into 3 groups, you can see how they separate. So again, the hard to treat phenotype in the red, it is clearly doing the worse, versus easy to treat phenotype, which is in green. And one can sort of, this is just based based on very initial baseline markers, so markers which I'm showing, which is just clinical demographic factors. If you add, in this database, you can also adjust for the different treatments, the different drugs. You can improve a little bit predictive value. And then clearly, if you add things like 6-month culture conversion and or on treatment sort of marker, you can really sort of get this ROC value to be above 0.8, which is quite actually, for me, I was very surprised that it was so high, because these are like all in a sense simple factors. You are accounting for baseline clinical markers and also early treatment responses measured by culture. And really what it comes to here is that the separation between these three phenotypes, it's very clear very much at the baseline. But, if you look to the right, once you include culture data, which is again common thing to do in MDR patients, when you treat them, separation becomes very clear. So basically, who are these hard to treat patients that they request, they need treatment extension, that the algorithm is very able to sort of say that. So I think that the same very much holds for treatment of MDR TB patients, and we are still learning with adding more and more data. Finally, so if we ask in this database by these phenotypes, some patients received shorter, some patients received longer duration, because there was so much variation between different sites and different clinics. And we could ask the question, if you're easy to treat phenotype and you received short or you received long duration, basically there was no difference in cure rates. Again, this is not a formal non-inferiority analysis because it's not a clinical trial, but nevertheless, we could see that there was no difference in cure rates. Again, these patients did well, even if sort of they went with a shorter duration per site sort of clinician recommendation at the sites. And then again, the same story, if you're hard to treat, if you did short duration, you didn't do well at all. Longer duration, you did better, but it was not good enough. Again, sort of driving that point that some patients need much longer. And finally, just sort of to build story one step further, we are doing exactly the same thing for pediatric trials. This is under the sponsorship of Unitaid in collaboration with the Stellenbosch University. So far, this is very much ongoing work, and we will be presenting some of these results at a union meeting. But the really nice thing about this database in pediatrics is that it's a very large, we have at this point around more than 20,000 children in the database. They're receiving the treatment for MDR TB across the world. Just sort of to show you the flavor of the database, the data coming from many places in the world, but clearly the most represented are India and South Africa. And just, based on what I've seen so far, the story is pretty much the same. And the hope is that when we integrate all of these data across many different trials and national programs, we can really make a very strong case, arguing the patients are not the same, and there's a phenotype of the patient that can help us manage the treatment and get patients what they really need to be cured. So just to summarize, I think stratified medicine in TB is not, has been really, like I would say, fought back. People want simple, people want like a magic pill and every one size fits all approach. However, my personal opinion is that won't solve the problem, and we have to sort of allow for a little bit more, at least stratification, not individualization, but at least stratification. Clearly reduction of duration is a huge advantage. And we can do it right now. We already have a very, very clear phenotype who can go shorter, and that can happen right away. That would clearly decrease the cost to programs and patients and so on. Stratified medicine is also a patient-centered approach, so really puts patients in the center, and we've sort of hope to select the best regimen with greater precision, and we are doing that in every other disease. We are arguing precision medicine is our future. Again, here, at least stratified medicine can be a step forward. And finally, I think the real point here is that with this approach, hopefully we can enhance cure and make sure every patient is cured, including the ones with severe TB, which would be a major contribution to the pandemic and what happens with TB down the road. And finally, like even if the sites or even if the world is not able to implement stratified medicine, I think you can always do one size fits all. So there's no really reason why, you know, if that's the only thing you can do, you can still go ahead and do it. But if you do have tools, and if you do want to do better for your patients, I think we are hoping that these large database analysis will sort of provide necessary tools. And finally, I think this is where at least our UCSF vision is growing. We are hoping to work out on definition of the right patient and the right treatment, and provide a number of solutions down the road, and maybe provide next generation of approach for finding the right treatment for the right patient. And with that, many people to thank, many funders, many data contributors, and including McGill and many of you on this call. And I really thank you for listening to me today.
Thanks, Nick.
Dick, you're still there?
Yeah, I'm still there. So thanks, Rada. Sorry I was late, and I probably have to go again. I'm on clinical duties and was doing a delayed bronchoscopy as you were starting. So thank you very much for giving the talk, for showing these results, which, as you said, are impressively consistent across many different populations, which is always kind of really helps seal the deal. I had a question before I go, just about the results in lung parenchyma and in the caseous, whatever, the casium. Are these results based still on some modeling, or are they based on actual, some sort of actual measurements in these materials?
Right. So these results are based on, so there are measurements. So there are actual data coming from both patients that went resection surgeries. So there's been a nice study that we've done in South Korea, where we measured PK levels in the casium for 7 different drugs, and that to pair those results in patients. It's clearly there was a small number of patients. I think there were maybe 15 of them. Clearly these patients are really hard to find. But we also have so we repeated experiments in a rabbit model for the same drugs, and trying to sort of understand if the same happens, if the rabbit model can be proxy for these patients. So there is a pair of animal experiments and human experiments and human trial data for 7 different drugs, and results are the same. So basically what you see in rabbit, you'll be also seen in patients, and that's where we sort of can trust this lesion penetration ratio, or like a poor penetration of the drugs in the lesions.
So if I got it right, INH, RIF, PZA, ethambutol at current doses don't seem to get into casium at all.
Rifampin gets in. Rifampin does get in. Yeah.
Rifampin gets at current doses, sort of 10 milligrams per kilogram, you can achieve something at least, although it seems to be monotherapy, is your point.
Exactly. And then I think that is the trick with high, with rifampin, it gets in some, and then clearly if you up the dose, you will get more. And then Moxie is the second drug that gets in. I think that's really like you have 2 drugs at the site for prolonged time.
And so, I mean, one thing is treatment shortening, but the other is, of course, the other end of the spectrum. Almost an equal number of patients need treatment, either lengthening or some intensification. So are you advocating, planning some sort of trial for these severe patients to look at ways to, treat them better?
Yeah, so I think, yes, we are hoping to do a trial within ACTG network on stratified medicine, and that's exactly what we are trying to do. We are sort of proposing longer duration for hard to treat phenotype, and stronger regimen and longer duration. So 6 months of HPZM, for example. And then for the easy to treat phenotype, the trial should, we still don't know how short we can go. We know that we can go 4 months, but we can go even shorter. And then the trial is meant to sort of shorten down to hopefully 2 months and see, how short we can go. So that's the trial we are planning. Yes, but any sort of trial that can validate better treatments for hard to treat phenotype, I think it would be very, very helpful to, to elaborate on this.
Okay, thanks. I'll pass the baton to Marcel and all the other, let everybody else ask questions, but thank you again, Rada.
Thanks, Dave.
Hi, Rada. That was really fantastic. And it's actually also kind of scary to think all these years we've been giving mono-riff therapy to caseous necrosis. And hopefully we learn from that. Are there any questions from the trainees, any of the students online who have a question? I'm monitoring the chat, but I haven't been able to see the pictures. Maybe if Rada goes away from screen share, I can see people's faces and maybe somebody is waving. You never know. Okay, until such time as Jonathan asks his question, no pressure. Rada, in one of the figures, you mentioned that one of your risk factors or your correlates was called extrapulmonary TB. I'm an infectious disease doctor, so I see scrofula as TB mild and TB meningitis as TB scary. How do you bin together extrapulmonary into a thing? And does this have to be spread out into different extrapulmonaries?
Yeah, I'm 100% with you there. I think it has to be spread out. I think it's just, for us, it was the way to take it out, from pulmonary TB, but it's a very different approach. Clearly, meningitis that is devastating and that needs much sort of more intensive treatment. And I think it requires its own sort of detailed analysis to understand what are the best approaches for those treatments. Yeah. But the fact is, it is definitely different than pulmonary. I think really the intention with that risk factor is to say it is different and worse.
And just to be clear, when you're talking about extrapulmonary, you're saying people who had pulmonary TB and also extrapulmonary? Because another thing I learned when I was in San Francisco is if you looked at all the people with extrapulmonary TB, and then you looked in their chart to see if they actually had a chest X-ray and a sputum, a lot of people assigned extrapulmonary TB didn't even have pulmonary investigations. So if you make the effort to do pulmonary investigations, maybe 30 or 50% of them will now be rebranded as disseminated TB, or at least multi-site TB.
Right. I think that's all very valid. Like, we don't have that level of details in any of these program databases, but I think it's a very valid point that certainly needs to be, looked into.
Okay, well, hopefully you'll get the answer, because every time I see somebody with TB of the bones or something, I send an email to Véronique Dartois and say, do you know which drugs get in there? And it's MDR TB, and she says, that's a good question.
Yeah,
but that doesn't help the patient in front of me. I'm looking at the pictures here. I'm failing to see the hand that's waving at me. But
I have a hand, Marcel, if you want.
Thank you, Jonathan, for that spontaneous offer.
Yeah, no problem. I have more of a, well, first, Rada, thanks for a great talk. I have more of a, I guess, translational question on how we move kind of from this work and getting it into a clinic where physicians they have a TB patient in front of them. Maybe they're not treating, the number that Marcel or Fads or Dick treat each year. They're treating a few. How do we get this kind of precision medicine to them? I saw you had like the online tool, but I mean, how do we translate that down? And then how many, like for new clinical trials, how are we getting these into kind of looking at new regimens? Because even in study 31, right, you highlighted the high rifapentine one appeared to look just fine in the in your so-called easy to treat population, but it comes out and says it's non-inferior, and everybody who's kind of not up to this on the literature looks like, oh, this regimen is something that we should investigate further. And then I guess the more complicated is, how do we move this from a high income setting to more resource limited settings where the majority of TB patients are, and clinicians really probably just want an easy one size fits all approach, which, I mean, you've elegantly shown is not ideal.
Right. So I think, this it all comes with guidelines and evidence and recommendations. I think one potential problem with all of these analyses, this is all retrospective. So it is all looking back and basically, trying to learn from all the conducted trials. I think, one piece of clear evidence will be prospective trial where when you clearly show in a randomized setting that this is a better approach, and then hopefully that's the way to get into the guidelines, and either, is it CDC or WHO or depending where we go. So I think that's one way. Usual criticism is that we need prospective sort of evaluation, even if you have a huge database showing you that you already can do things, but nevertheless, so that's why I think we are doing the trial. That's our next step. And the second, how you bring it to a clinician, clearly, we have the tools, but we can make these tools, if it's in the guidelines, then we can sort of sort out how to do it in a more professional way that can be integrated with electronic health records, or with the system. So that can happen, but I guess it needs sort of the impetus to be endorsed. This is how we want to treat going forward, and that's where the guidelines comes in place. And finally, how do you transition in low resource setting? As I said, none of these tools are not. I mean, these markers, they're all collected. So most of the clinics in the world, you have to diagnose TB, you have to, most of them do chest x-ray, most of them ask the patient if you're HIV, and most of them can measure the weight. So I think that's all you need to know. And hopefully you can tell if patient is a man or a woman. And that's all you basically need to know in order sort of to help with the approach. So just, I think markers are available. It's just a matter of sort of, working out an implementation side and how to do it. So we're not asking for PET CT or anything like that. I think this is always meant, to do simple. And even if you don't have markers, as I said, you always have a, approach of one size fits all.
Thank you.
Thanks.
Rada,
Chris.
could I ask one more question if you have a moment and nobody else has a question?
Yeah, please go ahead.
Actually,
I think
myself.
yeah.
I think
Evan.
Christelle and Faz have.
Okay, I'm looking for the hands up. Great, I'm glad other people have questions. Christelle. Sorry, I see them now, yes.
Yeah, good afternoon or evening. Sorry, I cannot turn on my camera because it's important for me to improve the internet. I'm joining from Cameroon, so I was interested in the study. And my point of view will fit with Jonathan, because practically if you're in an urban setting, you can easily ask a patient to do a chest x-ray, for instance. But even to have generally we diagnose patient based on the smear microscopy, and not everyone have access at least to the biomed and the rapid molecular testings. So I'm wondering how really practical we should be able to implement this in our setting, as well as so far, if I look at the drug-resistant cases, it has been easy for not easy, but practically the TB programs are able to manage patients in a standard way. So when I look at the division of patients like low risk, middle, and high risk, and then the treatment that follows, I'm a bit concerned how to capture this on the field and be able to report this in a very concrete and I don't know, very practical way, it's a bit challenging for me. I don't know whether you have a comment about it, but though it's a great presentation, great insights, it's good to see about the look how the research is evolving. And yeah, thank you.
Thank you, Bristol. I think that's an excellent question when it comes to implementation. How do you really make it useful and practical? Yes. So the point is that there's like a number of markers that you can use. But even if you don't have all of them, let's say you said you don't have chest X-ray, you have smear, and you are able to measure patient weight, and you are able to ask if patient is HIV positive or not. So you can still sort of use those markers. You don't have to have everything in order to sort of understand if this patient, to start with, you can stop the treatment sooner or later. I think they will all start the treatment. The point is when they can get off the treatment. And again, that is the decision that you can make at 4 months and say, okay, you were easy to treat to start with, based on what you had, when you initiated the treatment. And if there's anything else that you concerns, you can actually make a decision to stop it sooner, and for some others to actually prolong the treatment longer. So I think it can be very practical and sort of suited to what you have, what tools you have to work with. And then if you don't have any tools, then you just do, whatever you would do anyway.
Okay, Faz, next.
Hi, thanks again for that. That was a really great talk. I'm one of the researchers at the TB Center, and some of the research I do focuses on CAD programs, which those computer-aided detection, these AI-based programs that analyze chest X-rays for TB. And it's made me, some of that work has made me reconsider how we use X-rays in TB diagnosis and management. And so I noticed in these precision scores, it's based on the presence or absence of cavities. So I assume this is from data that is all human read X-rays reported in some form of variable in these databases. And so I've been wondering if you have thought, or if you know, if the actual X-ray images are available from these studies or through critical path, because CAD analysis gives you a more quantitative, say more objective analysis of an X-ray image that could, I think, maybe further enhance the precision and maybe even generalizability of these kinds of models. So do you know? And
yeah, that's yes. So you're absolutely right. The chest X-ray readouts are done by clinicians according to the protocols by clinical trials, and we know there's a large reader-to-reader variability, and there are tons of problems with that. So yes, it would be amazing to have automated read and sort of more standardize that part and have more precision. I am positive that will sort of improve the precision of the algorithm as well. And at least for study 31, I think there are a number of digital X-rays available. They're not all physical, so so there is a way to sort of elaborate on that and work more on that. And I'd be happy to connect and discuss it. Clearly, we have everything else in the house. We don't have digital X-rays yet. We always sort of plan. It was somewhere there. We should sort of do things that you're mentioning, and it's definitely a gap and opportunity to keep working on this.
thank you.
All right. It's already 10 minutes beyond, which Rada means that everybody actually wants to stay late, which is a great sign, but we have to release you to go back to your work and let the people here off for the rest of the afternoon. So thank you for zooming in from San Francisco. Hopefully next time you can come join us in person. I have many more questions for you, so hopefully there'll be opportunities. I sent one by email, and just thank you again for a great talk.
Thank you all for having me. Have a wonderful day.
Okay, bye-bye.